Good morning, everyone. First of all, let me congratulate Dr. Khatri and his team for thinking of a conference on pedagogy. Case-based learning has been pretty prevalent in physiotherapy teaching practice. But having spent almost 3 decades in a profession, as a student, as a mentor, as a guide at various levels, I feel that so many things have changed over a period of time. Right from medical practices, recent advances, student-teacher ratio, student-patient ratio, and variations in pedagogy practices over different institutes. So my purpose here is that how do we change with time? So many things have changed in the environment and we need to keep up the pace. So though the concept is officially introduced in 80s, but the case presentations and on-patient teaching was on even before 1980. As teachers, our primary purpose is to groom our students, to see them as future therapists and just not a current student. So a lot depends on how you see your student 5 years down the line, 10 years down the line. How does your student see oneself in a real world? They may choose academics, they may choose a research field, they may choose academics, they may choose domestic care. Whichever area they choose to practice, there are certain areas which are going to overlap. So as a mentor, I would like to look at what is our role as a teacher, what do we expect from our students, when we are selecting a case which could be either real or simulated, what are the points to ponder over, and last but not the least, selection of case and practices of case delivery. We all know the learning pyramid that if you just tell someone, they may forget. In an official teaching environment, they will remember. But when they are really involved into something, they will learn. And involvement is just not restricted to group practice. They are held responsible for what they do. And only then and then they will learn. Next level could be preceptorship, where you could recruit your student as a facilitator. But in my opinion, we can save it for PhD students as well as MPT students as a part of learning process. Though this discussion is just one part of a total picture, the prerequisites are going to be sound theoretical knowledge, technical competence, clinical reasoning, which is supported by relevant evidences. Because ultimately we aim at an effective treatment. Nobody treats investigations, nobody just practices because there are recent advances. The bottom line is your patient has to recover and recurrence has to be reduced, for which these primary data are very important. It's a tripod, and the three bases are student, teacher, and a case. Sometimes we say that no study happens in a group study, and little bit of it which we can permit. But as far as the case discussions are concerned, let them relate to the characters and circumstances of the story, which is the case. They all will have their individual perception of the problem, which is welcome. Let them have their own perception, welcome their own contribution of their own problems, and encourage open and unbiased discussion. That's where you are going to be required as a teacher. Let them invite questions, let them encourage questions, let them defend their position, what they are doing and why they are doing. As a student, it may not be important because their vision is restricted to exams. When they work in the real world, there will be team discussions with surgeons, there will be team discussions with physicians, there will be exchanges with relatives. So on their part, it's very important to be clear about the rationale of their practice. And whatever solution they formulate, Let that be based on the data that they have collected. May it be history, may it be their clinical examination, may it be their clinical reasoning. But their solution has to come from the patient data and not from theory or evidences only. There is going to be a byproduct that there will be disagreements. Sometimes two heads are better than one, sometimes they are not. So there will be disagreements, and that is also a part of learning process because this is what they are going to face in their real life. The added advantage, which is very significant, is development of social skills. Most colleges do not have development of social skills or communicative skills as a part of their curriculum, but indirectly this can be incorporated. They will learn to analyze case as well as they will learn to analyze the situation. They will work on their communication skills, communication amongst each other, communication with a facilitator, communication with a physician. They will learn to collaborate, and physios most of the times work in teams. So we are not only team leaders, we are team members as well. So collaboration is a very important part of physiotherapy practice, as well as content knowledge. That is the base. What you are sharing is not your personal opinion. What you are sharing is content knowledge. So social skills are not ahead of the list, but they are definitely significant part of learning when it comes to students. So what will be the learning goals for students? That will vary according to their cadre, which we will talk about a bit later. And it's not compartmentalized that what you learn in first year, you forget in second year, what you learned in third year, you forget in fourth year. They have to learn to integrate their previous year's knowledge and put into practice by the time it comes for clinical case discussion or treatment delivery. The social skills, problem solving skills, learning skills are going to be with them lifelong. They are not just going to be restricted to college. That take home message stays with them for life. Some of them will be better at it, but they will definitely develop leadership skills and teamwork, and that should be rather the one of the learning goals. Communication among students will improve. They will learn to develop quality circles. They will develop critical thinking, and critical thinking based on facts, critical thinking based on analysis and due reflection. And I personally do not encourage do as directed practice. You are going to be an independent therapist. You have to have your own thought process. And especially with master students and further, they have to think on their feet. Undergraduate students, we can still permit a little bit of obedience, strong word though. But masters and further, they have to think on their feet. So, in a nutshell, they are going to improve their medical, social, psychological, philosophical knowledge, as well as we are grooming them to be an independent, approachable, competent therapist. There can be a little bit of overlap between active learning goals and advantages. But when you take up and see case-based learning as an individual pedagogy practice, this is an opportunity to see theory in practice. Now, how does it matter? Let's say, for example, rheumatoid arthritis has certain clinical features. Now, all patients need not have all those features. There are some complications listed, but not all patients have all the complications and neither to the same extent. So, what we advise them is look for your patient in a book. Don't look for your book in your patient. There are 5 points written here, and this patient has only three. That happens. And patients progress over a period of time. Another advantage will be that there will be exposure to multiple viewpoints. When there are more than one heads involved, there are likely to be differences. So one, they will learn to handle those differences as well as they learn that there is another way of looking at the same problem. So that kind of ignites their mind, which is very important. And they will learn scientific conclusion, which is based on data analysis, clinical reasoning, and evidences, and not on assumptions or just borrowing somebody's opinion. And I have seen that when you give them this liberty, there is more engagement, interest, and involvement on students' part, which facilitates their learning. Especially with master's level, if these are the things we are expecting from students, then why teachers are needed? There is a disadvantage of leaving it entirely onto students, and it is best depicted by the elephant example. Everyone will have a different view, but as students, they are not able to see a total picture. And we do not want this example being repeated. And that's where teachers are required. What is our role as teachers? What we have witnessed, what we have experienced in different learning atmosphere when we were students, learning from that and implementing in our current practice, and where we need to change, what we need to focus on as teachers. Teachers are not someone who is dictating or imparting knowledge over here. Our primary role in a case discussion is that of a facilitator, not even a referee, just a facilitator. We need to encourage exploration of the case, not only permit, but invite questions. And you have to create an environment where students feel free to ask questions and they are not scared, they are not offended. Create that environment, which is easier said than done, but as teachers, we need to do it. And we have to have an unbiased view. What we expect from students, first, we have to practice that. If we want an unbiased discussion, we ourselves have to be unbiased in the first place. And we have to respect participants' perspective. See, there are many gray zones in medical and physiotherapy practice, that there are not just one correct way of dealing with a patient or solving a problem. And going by the first law of medicine, do no harm. If they are not harming the patient, they should be allowed to permit their own way of practice. But what we discuss is there are possible ways of treating a patient and let them work according to their own strength and conviction. Conflict resolution will be a facilitator's responsibility, but I suggest that has to be done professionally rather than making somebody right and the other person wrong. Just look at it as a different perspective. There are very few things which are right and wrong, they are just different, and that has to be encouraged. And as I said earlier, if you are a teacher or a facilitator who's handling cases, then you have definitely spent some year in physiotherapy practice, either as a teacher or as a clinician. And what matters is your vision here. What they are not able to see at student level, you are able to see as a teacher. So your vision is extremely important here, and you are able to see a total picture. Sometimes, especially with master students and PhD students, we give students a role of a facilitator. And we are not passing the buck. I'm not available, so let this student carry on. No, that's not the purpose. Going by the learning pyramid, when we involve them, their learning is around 70%. But when they actually teach what they have learned, their learning is around 90%. Going by this principle, if we ask them to be facilitators, their learning will go a step ahead. But this will be after they have crossed the level of involvement. Then the level of preceptorship will come. May not be a good idea to make it a common practice. This will rather be based on individual merits. You can see their mark sheet, their extracurricular and teaching activities through group interviews to see how they handle people, how good are they on conflict resolution. And before you give them this role, ensure that you train them for this role. You may give them a first case just to see how well they are doing and point out areas where they need to work on. But that is okay for the first case. For the later on practice, train them to play this role and then assign them facilitators role for junior students. And this training program has to be specific to the physiotherapy practice, because whatever applies to medical practice, may not be able to extrapolate to physiotherapy practice. So train them to handle conflicts and cases which are pertaining to physiotherapy. Let's talk about the food for thought. We have reasonably clear expectations from students. We have reasonably clear expectations from teachers. Now, case is basically their food for thought. And that's where their thought process develops. And as a teacher, what you are doing is you are channelizing their thought process. You are helping them to remain focused. So your case can be extensive, but which is more common in business, law, and economics practice. Case can be descriptive and narrative, which is very common in physiotherapy practice. You can split up the case into smaller problems, and it can be a mini case, which is more recruitable in the initial practices. Could be just bullet points or MCQs. We have to give them food for thought, but just minimum which ignites their mind and invites question. If you give every detail in the beginning, then there is nothing left for them to question. So when we are selecting a case or we are introducing that model, what we expect from a case? It has to tell your patient's story. It has to arise their interest, preferably recent. What I practiced 30 years ago is not relevant anymore. So, and need not be the recent most, but at least last 5 to 10 years at max. See, empathy for your students and patients. You can use quotations. It has to be relevant with the current practices. And last but not the least, it has to be pedagogic utility. When you give them a case, your learning objective should be clear. And at the end of the case, your learning objective should be fulfilled. We don't mind if you make bite-sized cases in the beginning and later on you can give complex problems. That is absolutely welcome and recommended. Sometimes you will force decision, not as in do as directed, but at the end of 40 minutes or 1 hour or 2 hours that you have given them, they have to come to a conclusion. So data has to be good enough to force a decision that what are you going to do about this problem? How are you going to solve the problem? What is your future plan about it? And in some cases, there will be general application. Some things will be case specific. Keeping these in mind, our role as teachers becomes very crucial in selecting and delivering the case. Case can be real or simulated. What happens in clinical practice is that either you see the same patient over and over again and you have one patient data over a period of time, or it will happen that for a given diagnosis, you see many cases and the variations of presentations. So whatever case you give, preferably it should be based on facts. You can start with simpler ones, but eventually you progress to complex ones, which invites discussion and collaborative analysis. Encourage interaction. Let students explore on their own and give them realistic and specific situation. More specific the cases, more clear you are on your learning objectives, it will be easier to attain them and the student learning will be more accurate. How do we practice all this? It's a good idea to start slow. Let's say, and a little bit of pre-planning definitely helps. Don't just go by diagnosis that this is a case of osteoarthritis and it is given to the patient. What are the impairments? What do I want to teach my students? What is the take-home message that I want to give them apart from the team dynamics? Pre-planning, out of 52 weeks of a year, if you consider exams and vacations and other things, you still have 30 weeks left. That means 30 cases. If you go once a week, that means 30 cases in a year. If you divide among specialties, you are still having almost 7 cases a year. You can start with a simpler problem and add to the complexity. So at the end of a year, they are able to sort this out. So a little bit of pre-planning helps. Where group work is concerned, group dynamics will be there. Not all of them are going to be friends. They will have their personal preferences. And as teachers, we are also not immune to this. But let that not be a barrier. When you are discussing the follow-up case, let that be with the same group as it would happen in your class. That this is the case for a fourth year, this is a case for a third year, this is a case for an MPT, or this is a specialty case that only cardio MPTs are discussing this, or only rehab MPTs are discussing this. So try to work in the same group so that they can relate to the case. And as far as learning is concerned, there is no overlap of an effort. And there has to be variation according to cadre of a student. What case I'll give or what my expectations are from an MPT student, they are not from a fourth year student. So we have to be reasonably clear about our expectations from our students. What do we mean by variation according to cadre? If you see the program structure, first year they are pretty new to the scenario. They are getting introduced to health sciences. They are still learning their basic sciences. So we refrain from giving them a clinical case. But we still want to work on a teamwork. We still want to work on social skills. So rather than giving them a real case, give them a virtual case, which incorporates whatever courses they are taking, and their social skill and communication skills will still develop. Some colleges have languages as a part of curriculum for their own reasons, but it's a personal recommendation that include communication as a curriculum somewhere. If you are not able to incorporate in your syllabus, then ensure that when you take your practical sessions at the end of fourth year, your students are good with communication skills. And that is independent of the language they speak. Typically in second and third year, they are learning therapeutic techniques, assessment techniques. So a lot of technical competences here. So you can still divide them into actual small groups where when they learn assessment, they can at least form a hypothesis or they can list impairments. So work with that expectation at that level. Fourth year, we expect a little more. They have basic sciences, they have technical competence, they have assessment techniques, and some sort of clinical reasoning. So at fourth year level, you can give them the task of developing a treatment plan, which you do not expect from second or third year. And there will be a lot of real life application of communication skills and whatever they have learned in previous years. And this is something which is work in progress. And as we talked earlier, you are going to have at least 7 sessions with them per subject. So you will be able to design their cases very well. To simplify, I'm sorry for the spelling error. The 4 R's of CBL are retrieve a similar case. You can reuse the case to solve the same problem. This will happen in real life. This patient was us 2 days back. This is how we treated. And after 2-3 days, this is the picture. So you are reusing the same case to solve the problem. Was the problem solved? If yes, to what extent? If no, why not? So your 5W and 1H approach is going to be helpful here. And it may happen that you may have to revise your solution, that you decided on something, you delivered that to the patient, you reevaluated and at an appropriate interval, you reevaluated and the treatment is not effective. then you have to revise your decision. That doesn't mean the previous decision was wrong, but at that time that didn't turn out to be a best practice. And when you get a new solution, you are retaining new solution as a part of the new case. So this kind of channelizes your students' thought process. Almost coming to the end of the session, this is more for us, how to select a case, or for student who's a facilitator. See, our patients are like open book. There is so much information, some which we want to focus on, some we can focus on later. So everything that is presented in a case file is not our purview. So select only the necessary processes and data so that you can maintain accuracy in case presentation. You can split the data into small pieces, make it bite-sized information to be digested better. Sometimes just for learning process, we may use a contradictory data, that how do you analyze this? How do you come to conclusion? Because sometimes you will be generating conflicts to reinforce their conflict resolution. And even when it comes to further analysis, select only the relevant data, because most case presentations are going to be time bound. And if you repeat everything every time, you won't have time to focus on your learning objective. So to maintain the accuracy, select only the relevant data for further analysis. Every time history may not be repeated, every time certain data need not be repeated. And if you're working with the same group, or if you're repeating the case, these details are already known. So when it comes to further analysis, select only the relevant data. How to deliver a case? Easier said than done, actually, because your objective is student learning, and as we discuss further, which is different from just giving them information. You are giving them food for thought, but you are giving them in bite sizes. You are giving it in the digestible form. Uh, Even the method of case delivery has seen so many changes over a period of time. We have a big time advantage of technical advances. So use technology, make a system with case information, and allow students to interact. You can just make a PPT and let student interact. Earlier days, that would be, I've heard from previous generation that in 50s and 60s, the discussion was only on patient and a lot of learning happened during rounds. In our case, you can include that, but if you can have a theoretical case discussion as well, and ensure that all the participants has seen the patient so that they are not living with a lot of imagination. We verify case content or supervise case content preparation from a facilitator, but we have to see how they are discussing. We have to encourage questions. What is the team dynamics like? And from your end also prepare an outline of concepts, sub-concepts, and which are to be incorporated in case discussion. The way you have your learning objectives, you have your own objectives also, that I want to teach this concept and how well it is being delivered. Sometimes a list of leading questions are also helpful. You give them a freedom that they ask you anything without being ridiculed. But you have a certain agenda. Your vision is going to be different and welcome from your students' perspective and from their vision. So list of leading questions are of help. That some things which your students are not able to see, but you are able to see. Then plant that seed in their mind and they'll be ready to work on it. These are not really recommendations, but this is how I have seen practice changing. And when it comes to a case discussion or a case-based learning, this is how I see the process. And I have a certain recommendations. We need to groom teachers as well as students and incorporate communication skills in your curriculum, formally or informally. Again, thanks, Dr. Khatri and team, for planning this conference and giving us this matter of pride and pleasure to be with you. Thanks a lot, everyone, for patient listening.